This is the Interim Joint Committee on Health, Welfare, and Family Services, meeting number 7. The date is Tuesday, November the 23rd. Madam Secretary, please call the roll.
Senator Rocky Adams. Senator Berg.
Present remotely.
Senator Carroll.
Present remotely from out of state.
Senator Givens. Senator Harper Angel.
Present remotely in the district.
Senator Howell.
Present remotely in my district.
Senator Kerr. Senator Meredith.
Present in the room.
Senator Nemes.
Present in the room.
Senator Wise.
Present in the room.
Representative Bentley. Representative Bowling. Representative Bray.
Present in the room.
Representative Birch. Representative Dotson.
Present remotely.
Representative Elliott. Representative Fleming.
Present remotely.
Representative Frazier.
Present in the room.
Representative Marzian. Representative Gibbons-Prunty.
Present in the room.
Representative Rayburn.
Present in the district.
Representative Raymond.
I'm present from my district.
Representative Riley.
Present room.
Representative Sharp.
Present in the room.
Representative Sheldon. Representative Tate.
Present in the room.
Representative Weber.
Present in the room.
Representative Westrom. Representative Wilner.
Present in the 35th House District.
Chairman Alvarado.
Present in the room.
Chairwoman Mosier.
I'm here in the room.
Very good. All right, we have a quorum, so we're constituted to do business. The first order of business, and I think Senator Rocky Adams is also here if you want to get her on the roll call. First order of business. I'm sorry?
Representative Bowling's present from the Annex office.
Thank you very much, Representative. Anyone else that wants to answer the roll? All right, thank you. So the first order of business is approval of the minutes from our October 20th, 2021 meeting. Do I have a motion?
So moved.
Is a motion? Is there a second? A second. All those in favor, please signify by saying aye. Aye. Any opposed? Aye. All right, the minutes are approved. The next thing we're going to take up is going to be our regulations, item number 6 on the agenda. These have been posted for several days now. I've had an opportunity to review these. I don't see any issues on these regulations. I don't know if there's any questions, comments, concerns about those regulations. All right, seeing none. If anybody's online, we thank you for being present to be available to answer questions. Those will stand as being reviewed by the committee. All right, we've got a good agenda for discussion today on some topics that some may consider to have some controversy, but I think they're important for us to have some discussions on and to hear a presentation. The first item we have is scope of practice in healthcare. We've got 3 individuals who are here to testify. One is in person. One is Corey Meadows, Deputy Executive Vice President, Director of Advocacy for the Kentucky Medical Association. And we have 2 remote presenters, Dr. Susan Bailey, who's the immediate past president of the American Medical Association, and Kimberly Horvath, who's the senior legislative attorney with the American Medical Association. We'd like to welcome you all. If I've done kind of some introductions, but if you'd like to introduce yourselves briefly for the record and begin your testimony.
Well, thank you, Chair Alvarado and Co-Chair Mosier. As many of you know, my name is Corey Meadows. I am Deputy Executive Vice President and Director of Advocacy for the Kentucky Medical Association. And as always, I appreciate the opportunity to speak with you, including today. I'd like to reserve a majority of my time for our guests from the American Medical Association. But before turning it over to them, I would like to provide some background on this topic known as scope of practice. First, what does scope of practice mean? Oftentimes the term is used, but many may not fully understand it. Simply stated, scope of practice is the set of healthcare-related activities and procedures that an individual is permitted or authorized to perform. Before performing such activities and procedures, however, the individual must demonstrate that he or she has the requisite level of education, training, and competency. It's also worth noting that a provider's scope of practice can also include express limitations that may restrict what an individual may do as a part of his or her practice. Determining these two things, what a healthcare provider can or can't do, is meant to ensure quality of care and patient safety. Now, when we talk about scope of practice, that applies to every provider. It's not just a APRN issue, it's not just a PA issue, it's a physician issue, it's a PT issue, it's an audiology issue. All providers have to deal with that. So with that definition in mind of what scope of practice is, this begs the question, who determines scope of practice? Scope of practice is determined state by state. That means state legislatures, like you, start by enacting a practice act for each provider group. Again, physicians, nurses, pharmacists, athletic trainers, occupational therapists, physical therapists, I could go on and on. They all have a practice act. Those practice acts establish what services can be performed or not performed, how they are to be performed, and by whom. Following the passage of the law by you, the legislature, regulatory bodies, our state licensure boards, then step in per your direction to create regulations and rules around that practice act, which are supposed to be in the interest of best serving the public, not necessarily in the best interest of serving that provider. It's about public protection in many ways. That, in a nutshell, is how a provider group's scope of practice is developed. Now, a question that comes up quite frequently is, if that's what scope of practice is, if that's who gets to determine it, why is scope of practice often a difficult topic to discuss? Healthcare practitioner groups approach state legislatures all over the country. I'll have you know that even though we see scope of practice legislation each and every year in Kentucky, that's not unique to our state. This happens in every state. Every year, different scope of practice pieces of legislation. And what groups do is they approach their legislature making any number of requests related to scope of practice, oftentimes independent practice, which means, just so that we're clear, independent practice means no required supervision or even collaboration with a physician. These groups typically base their arguments for independent practice on factors such as consumer demand for their services and undersupply of specific healthcare practitioners or services, unmet needs in rural settings, changes in reimbursement policies, and other myriad of justifications. As you might expect, these arguments raise significant concerns from other groups, including physician associations, regarding the true need for such expansions in scope of practice, especially when the public safety may be at issue. These types of debates, honestly and candidly, they oftentimes put healthcare provider groups who are all well respected, who all have the same mission of providing quality care, but unfortunately these debates oftentimes put groups at odds with each other. And based on what I've experienced, these types of debates also put lawmakers in an either-or scenario or proposition. Because lawmakers want to be responsive to each group's concerns, such a scenario leaves them, you, oftentimes in a difficult position as well. In short, it's a delicate balance between what some will call access to care versus other groups' serious concerns about public safety and quality care. But I want to be very clear. Regardless of the issue or who is requesting it or what group is requesting it, the Kentucky Medical Association firmly believes that first, patient safety should always be the overriding objective when evaluating any request for a change in scope of practice. Second, to ensure public safety, any request should incorporate what I will consider the overarching message that we have for you today, and that is physician-led team-based care, the team-based care model. Notice I don't say just singularly physician care model or just NP model. It is a team-based care. This will ensure and promote efficiency and high-quality care for the patient. Now, even though I have acknowledged that oftentimes these debates put groups at odds with each other year in and year out, I don't want to leave on that note. I want to offer you some positive examples of how when groups come together, how they can and should work when addressing these types of issues. For example, physician assistants, the Kentucky Academy of Physician Assistants. And I think some of you have sponsored some bills in the past related to physician assistants. A couple of sessions ago, there was a request for them to be able to have prescriptive authority for controlled substances in certain circumstances. Obviously, we were very concerned at the initial request. However, we had questions, and to CAPA's credit, they approached KMA, and over the course of several weeks and months leading up to the forthcoming session, our concerns as an association were heard, and we were able to ultimately reach compromise on a number of issues which led to the enactment of that legislation. Athletic trainers. As many of you all know, recently athletic trainer legislation was passed. They had some requests to be able to more clearly define their practice act, be able to do more things, whether that be on a football field or a basketball court, because a physician and a nurse practitioner and a PA, they can't always be at athletic events that many of you all have in your districts. And so they wanted the ability to be able to go out and offer their services. Again, we had questions. We said, what's this about? What all would be involved? We came together again over the course of several weeks and months, and ultimately, because of that cooperation and collaboration, legislation was ultimately enacted by the Kentucky General Assembly. Nurse practitioners and PAs again. In the most recent session, there was a home health agency bill that would have allowed nurse practitioners and PAs to be able to formulate and ultimately sign off on treatment plans related to home health agency services. Again, to their credit, the home health agency folks approached KMA and said, this is what we would like to do. And after roundtabling it with our legislative leadership and our clinicians, they said, actually, this would be a very good idea. We have no issue with this whatsoever. It will help with the continuity of care. So again, I just offer those of examples of how things can and should work on these difficult issues about scope of practice. And so with all of that as background, I would like to turn the presentation over to Dr. Susan Bailey and Kim Horvath from the American Medical Association so that they can provide additional information about what you should keep in mind when making policy decisions that have scope of practice implications. Dr. Bailey, if you're there, the floor is yours.
Yes, I am here. Thank you so much. Kim Horvath is going to share and advance my slides. I'd like to wish good afternoon, Chair Alvarado, Chair Moser, and members of the Interim Joint Committee on Health, Welfare, and Family Services. My name is Dr. Susan Bailey, and even though I was born in Kentucky, I'm a practicing allergist and immunologist from Fort Worth, Texas now, and I'm the immediate past president of the American Medical Association. I am so grateful for this honor to be here today to testify to you on behalf of the AMA. I'm pleased to talk with you about scope of practice and its impact on patients in Kentucky. These issues are very important to the AMA and physicians across the country. So I'd like to share with you some information on three key areas to inform your perspective on scope of practice. First, education and training. Next, the cost and quality of care. And finally, access to care. Next slide, please. But first, let me start by providing a national perspective on scope of practice. As an example, I'd like to offer a couple of maps to provide some context of how Kentucky compares to other states in the country. As you can see in this map regarding nurse practitioners, where the darker the color is, the more supervision is required by that state. Kentucky's laws are consistent with your closest neighbors, supporting physician-led team-based care with regard to nurse practitioner scope of practice. Next slide, please. And in this next map, looking at physician assistants, Kentucky's laws in this situation are also comparable to and consistent with the rest of the country, which overwhelmingly supports physician supervision or collaboration of physician assistants. Next slide, please. The AMA is a strong supporter of team-based care. We believe that all members of the healthcare team play an important role in providing care to patients, and that patients benefit the most when all members of the team work together. Nurse practitioners, physician assistants, nurse anesthetists, pharmacists, and other non-physicians are vital members of the healthcare team. Each have unique and complementary skills to physicians, but they are not replacements for physicians. And because of that, we believe that physicians with their unmatched education and training should serve as the leader of the healthcare team. Next slide. As you can see in this chart, physicians have the highest level of education and training compared to various non-physicians. The top 5 lines in the light purple show this. Between medical school, residency, and fellowship programs, physicians complete 7 to 11 years of education beyond college and at least 10,000 hours of clinical training. Now, in the lower part of this graphic with the white background, you can see that no other non-physician comes close to this level of education and training. For example, some physicians like podiatrists and chiropractors may require 4 years of postgraduate training after college, but they don't require residency programs and only require a limited amount of time caring for patients prior to licensure. Now, while these differences are significant, I'd like to point out that there's also a vast difference in the rigor and standardization of physician training compared to non-physicians. Next slide, please. So here's an example. During their 4 years of medical school, on the left-hand side, medical students receive a comprehensive education in the classroom and in laboratories, studying the biological, biochemical, pharmacological, and behavioral aspects of the human condition. And then we spend 2 years embarking on clinical rotations through different specialties, assisting licensed physicians in the care of patients. After graduation from medical school, medical students must then pass the first of a series of rigorous examinations to become licensed to practice medicine. And then physicians match into a 3 to 7 year residency program accredited by the Accreditation Council for Graduate Medical Education, or ACGME, during which they provide care in a select surgical or medical specialty under the close supervision of experienced physician faculty. Residency programs have rigorous standards which culminate in eligibility to take specialty board examinations. Now, as residents gain experience and demonstrate growth in their ability to care for patients, they're given greater responsibility and independence. And in fact, it's this increased graduated competency that's the hallmark of physician residency programs. Now, other non-physician programs don't have this same level of standardization or the same level of hands-on graduated experience. For example, nurse practitioners complete just 2 to 3 years of graduate level education and 500 to 720 hours of clinical training. They're not required to complete a residency program. And more than 60% of nurse practitioner programs can be completed either partially or completely online with no hands-on training at that level. Moreover, many nurse practitioner programs require the student to find their own preceptors for their clinical experience. Their curricula and their clinical requirements are not standardized at all. Now, this lack of standardization follows graduation, in which nurse practitioners must pass a certifying examination based on the population focus of their training. But once they are licensed, nurse practitioners aren't required to practice within this specialty. So a nurse practitioner trained and certified in primary care can practice in dermatology, cardiology, neurology, etc., immediately upon graduation and licensure, and can switch specialties throughout their career without any additional education. Now, this is markedly different from physicians who are trained in a specific specialty during residency and who often go on to obtain board certification in that specialty. Physicians don't switch between specialties throughout their career without additional training. Simply put, a physician's education and training make them uniquely qualified to lead the healthcare team. Next slide. And our patients agree. Patients recognize and value the education, training, and experience of physicians as essential to high quality care and support physicians as the leader of the healthcare team. 91% of physicians in this survey said a physician's years of education and training are vital for optimal patient care, especially in the event of a complication or a medical emergency. Patients overwhelmingly want and expect physicians to be involved in their care. Next slide. While some procedures or treatments may seem simple and uncomplicated, there are too many examples of practitioners with less education and training having bad outcomes that end up harming patients. Working together as a care team with physicians in the lead is critical to achieving the safest outcomes. Multiple studies have also shown that increasing the scope of practice of non-physicians has led to increased healthcare costs. This is due to many factors, but it includes increased prescribing of antibiotics and opioids by non-physicians as compared to physicians, as well as increased utilization of diagnostic imaging. Now, I have provided some additional information to the committee on this point, but I'd like to quickly share a recent study published in the Journal of Internal Medicine, where the authors compared the opioid prescribing patterns of physicians and other non-physicians. This study found that 6.3% of nurse practitioners and 8.4% of physician assistants prescribed opioids to more than half of their patients, compared to just 1.3% of physicians. And when comparing states that allowed nurse practitioners to independently prescribe compared to those that required physician involvement, the study found nurse practitioners and physician assistants with independent prescription authority for Schedule II opioids were 20 times more likely to overprescribe opioids than those states that had restrictions on prescribing. Now, these findings are supported by conclusions from other longitudinal studies on opioid prescribing, which found that nurse practitioners significantly increased opioid prescribing during the period of the study, while at the same time, physicians for almost every medical specialty decreased their prescribing of opioids. These findings should give you great pause. In fact, they highlight the fact that, like all areas of medicine, effective pain control requires a team-based approach. Opioid analgesics are appropriate for some patients, like those with a severe acute injury, those who have cancer or are in hospice, or with certain types of chronic pain. Now, these are all conditions that require close physician oversight to ensure the right treatment at the right time. Physicians have reduced opioid prescribing nationwide because of their increased judiciousness as well as their education and training. The data aren't clear as to why nurse practitioners are prescribing more opioids, but the bottom line is that breaking apart physician-led team-based care is not the answer to more effective care for patients with chronic pain. Next slide, please. We often hear that scope expansions are necessary to increase access to care, particularly in rural and underserved areas. Data show that this is a failed promise. Since 2015, the AMA has collected data on the practice locations of physicians and non-physicians across the country. State by state and year after year, the data clearly demonstrate that non-physicians tend to practice in the same areas of the state as physicians. This is true irrespective of state scope of practice laws, including those states that have allowed scope expansion. Next slide, please. Here's a good example. Now, Oregon is a state that's allowed nurse practitioners to practice outside physician-led teams for decades. Now, while the overall number of nurse practitioners increased from about 2,000 in 2013, the slide on the left, to 3,100 on the right, which is lower compared to the overall growth of nurse practitioners nationwide, you can clearly see that there's really no noticeable increase of nurse practitioners in the rural areas of the state. Next slide, please. We've seen a nationwide trend, in fact, that there's been a greater number in the growth of the number of nurse practitioners in states that support physician-led team-based care compared to states that allow independent practice. And Kentucky's a good example of this. Here is your map from 2013. Primary care physicians are represented by the dark purple dots and nurse practitioners by the blue, they're triangles, even though they're hard to see. They're found in nearly every county in Kentucky. Next slide. This is 2020. The number of primary care physicians and nurse practitioners both increased. In fact, the number of nurse practitioners in Kentucky doubled during that time, but they're condensed in the highly populated areas of the state. And just like in 2013, there are physicians and nurse practitioners in just about every county. There's not a significant drift of nurse practitioners into rural areas. Next slide, please. Another example showing the location of physician assistants in Kentucky. Next slide. And here comparing the location of primary care physicians and psychiatrists, which are the yellow dots, to psychologists, which are the blue dots, the blue triangles. And so these maps reflect the reality on the ground that physicians and non-physicians prefer working together in team-based care models, not separated into silos of care. There are likely other factors at play, of course. Expanding scope of practice, though, of non-physicians is not the answer to access to care problems in rural or underserved areas. Last slide, please. Now, there are some real long-term solutions to increase access to high-quality care, like physician loan forgiveness programs, state funding of physician residency programs, telehealth. Now, I know Kentucky has led the way with strong telehealth laws. Kudos to you for that. There's no doubt that when the recent legislation is fully implemented, it will have a positive impact on improving access to care for rural patients. So we implore you to support these kinds of solutions, as well as laws that ensure physicians continue to be involved in the care of patients and that patients continue to have a choice to see a physician for their care. Patients in Kentucky deserve nothing less. Thank you so much for the opportunity to present today on behalf of the AMA, and I'm happy to answer any questions. Thank you.
Thank you very much, Dr. Bailey. We appreciate your testimony. Just really briefly, I know that I'll ask a quick question. I know you had mentioned about some numbers there regarding APRN prescribing nationwide, and that the numbers were higher with some of those. Is that a study, a nationwide study? Is it state specific? Can you expand a bit on that?
That study was localized. The reference is in your materials. I should be able to find that pretty quickly here. Actually, this was looking at 2015 Medicare claims data, and it was really a nationwide study. And they found that when almost every medical specialty decreased their opioid prescribing in the same time period, nurse practitioners and PAs actually increased theirs.
So that's nationwide. It's not state specific,
yes.
Correct? So I know there's quite a few states out there where APRNs can prescribe without any physicians, and we've seen some of those maps here as well. I just want to make sure that was clear for the committee. Now, I know there's going to be members here. This is a discussion of some passion, and I know I'm included in that as well. So I know people will have questions about this. We'll try to go through them quickly. The first person I'm going to recognize is Chairwoman Mosier.
Thank you, Mr. Chairman. And hello, Dr. Bailey. It's nice to see you again. We've known each other, just for everyone's reference, through the AMA. I served as the AMA Alliance National President and worked closely with all of our partners at the AMA. So thanks very much for your presentation today. I appreciate your expertise and just some of the knowledge that you're kind of bringing and sharing today. I do want to point out that I brought the scope of practice wheels from the AMA for everyone, the Know Your Doctor, just to kind of outline the differences in training, and I think it's a handy resource. So, I know we've talked about standards of care, and we're talking about prescriptive authority a lot today. For consistency's sake, across states and addressing the standards of care, would it make sense to house licensure of healthcare practitioners with prescriptive authority under one body? And are there states who do this?
There are some there interstate license compacts that exist. Although the AMA, I don't believe, has policy on such compacts for non-physicians, we believe that each state has the right to license its own practitioners. So there is some debate about that. It might be helpful for data gathering, but since state scope of practice laws differ widely, uniform licensure might make things more complicated instead of less complicated.
Okay, a quick follow-up. I think I'm really addressing more about what goes on in the states, not necessarily an interstate compact agreement. Although we do have that in Kentucky, and I think it's serves its purpose. But for the practitioners who have a relaxed prescribing authority, so that would be anyone. That would be the PAs, APRNs, even pharmacists. If that ever comes about, would it make sense to license those individuals with relaxed prescriptive authority under one licensure body?
Okay, thank you for clarifying that. I think my personal belief is that having prescribing authority is practicing medicine. And I believe that everyone that practices medicine should be supervised by the same group and subject to the same liability law. That is a personal opinion.
Okay. Yeah. Thank you. And so do you know of any states who do this? And, is it improving the standards of care? Are we seeing a decrease in the prescribing in those states?
I am not aware of any. My colleague from the AMA, Kim Horvath, probably has a better answer than I. Kim?
Thanks, Dr. Bailey. Hi, everyone. My name is Kim Horvath, and I'm a senior legislative attorney at the AMA who works on these issues. And to answer your question, there are a couple states that have brought some of that oversight authority, shared oversight authority in certain instances, and happy to dig a little deeper for you and provide you with some concrete answers on that, Representative Mosier. And what I would say in terms of have we seen kind of improved quality of care with that? I think where we have seen improved quality of care is when there's the physician-led team. And I think we've seen that in for example, with the opioid studies that Dr. Bailey shared, in those states where there was, just to keep on the theme of prescribing, right, in those states where nurse practitioners and PAs had independent prescribing authority of opioids, they were 20 times more likely to overprescribe than in those states where they had to work within a physician-led team. So I think that is kind of testament to the importance of ensuring the safest care possible to patients that they're for prescribing, that they continue to work as part of a physician-led team.
Thank you.
All right, we've got 6 more questions. We're going to try to, we've got other things on the agenda. The next person I've got is Representative Bentley. Representative, I don't think your microphone's on. You may want to get that mic on.
Thank you, Dr. Bailey, and thank you, Chairman, for telling me my microphone wasn't on. But what I was saying was, I'm just a dumb old Kentucky boy from Eastern Kentucky, so I don't understand some things, so I'll ask some simple questions. Were we really talking about full practice authority or the scope of practice in your presentation? For does full practice authority, by your graphs, does it increase access of care, increase the cost of care, and create bottlenecks in our system, which is already fragmented? You know, there's 50 years of research out there on nurse practitioners in the United States. So my other question is, I was reading an article the other day. You know, my parents were married on Halloween, and Halloween is really creepy. So I was wondering if Dr. Bailey could explain to me what stop, scope, creep means.
Well, I'd be happy to. There was a lot of information in that question, sir. Basically, scope creep is a nickname, if you will, for expansions of scope of practice. And we believe that individual members of the healthcare team all have very specific roles to play, very important roles to play. And we believe that the increased education and training of physicians makes them qualified to be the leaders of the healthcare team. Individual members of the healthcare team are not you can't trade places. We need each one to do their unique roles. There is data to show that expansion of scope of practice does increase the cost of care, diagnostic testing, radiology ordering. There's a Mayo Clinic study that shows that it increases the number of referrals. And so we believe that physician-led teams with specific scopes of practice are the best for safe patient care.
And that's what stop, scope, creep means?
It means to limit the expansion of scope of practice.
That's what that means?
Yes, sir.
You know, on your chart on Education Matters, I am a PharmD. It looks like I came up the ladder a little bit. I have 4 years or more of graduate level education. I have 2 years of residence if I specialize, and I have 1,400 hours per year at University of Kentucky College of Pharmacy. But I wasn't included in this because I only dispense. There are other professions that dispense. So are you saying that when we rewrite these regulations, there should be no duplication of regulations? For example, a doctor can dispense? And that's my last question.
I am not, saying that at all. That graph was merely an example of the differences in levels of education between, some non-physician groups with physicians. It was not meant to be exhaustive, and only deals with as an educational piece on the level of education.
Thank you, Doctor, and thank you, Mr. Chairman.
Thank you, Representative. Representative Wilner.
Thank you very much, Mr. Chairman, and thank you for the presentation. I wonder if we could pull up slide number 5 again. Is that possible?
Hopefully so.
Thank you. This was the slide that Dr. Bentley just referred to with the training hours. And I just want to note in this Education Matters, as a licensed psychologist myself, your numbers are a little off. The years of patient care hours, there would be at least a year of practicum experience, then there would be a year of pre-doctoral internship. And here in Kentucky, at least a year of postdoc prior to licensure, so that 1 year should actually be 3 years. I would also mention that there's no such degree as a Psych D. We are either PhDs or PsyDs, or in some cases EdDs. And just, because this is an area that I'm knowledgeable about, for me, it raises me to have doubts about the other information in the presentation. I know that my profession is incorrectly represented. And it raises a larger question for me of why perhaps other groups, Corey Meadows did such a good job of talking about every provider has a scope of practice. And it would have been really nice to see some of those other providers included in this discussion and at the table with the AMA. It feels a little bit strange to have all of these scopes of practice defined by the physicians group. And I say that with deep respect and regard for physicians and all the training. If we could go on to slide 14, and I'll be very quick here. I just wanted to say that this maybe implies, and it's possible, Dr. Alvarado said emotions run high, but I think perhaps that psychologists are somehow in competition with primary care providers. That is certainly not the state here in Kentucky. In fact, the physicians I know who are fortunate enough to be involved in care teams with licensed psychologists are very, very grateful for the way the skills and the training complement one another, and things like management of pain without use of opioids and other behavioral implications. So I just wanted to emphasize that I thought that slide might be a little alarmist and a little bit misleading. And then finally, I just wanted to make the point that you talk about access to care as if it's an urban-rural issue. And while we know that that certainly is the case, in the urban district that I represent, we have huge pockets of poverty, and we have huge pockets of provider deserts. We have provider deserts all across the state of Kentucky, in our urban areas, in our rural areas, and in our suburban areas. And so finally, coming to the question here, with the access of care to care issues, with the shortage of providers in this state, the shortage of mental health providers, the shortage of prescribers across the state, I'm just wondering if you would be willing in future presentations, and if we hear this during the regular session, if you would be willing to have the other providers at the table with you to help inform this discussion.
If I may respond. First of all, Representative Wilmer, I want to thank you for pointing out errors on one of our slides. We will be sure to correct that. And and the point that I was making with, especially with the psychology slide, is how important it is for care teams to work together. And we welcome all providers to the table to discuss these things. And but I appreciate your input.
Thank you very much.
Thank you, Representative. I do want to comment that one of the reasons why we're having this group present here today, this has been a topic that has been presented in multiple committee hearings in other committees, licensing and occupation in particular, where there's this topic. The other side has been presented multiple times, with this side not having an opportunity to present its case. So they may have been allotted 2 minutes, perhaps. So that's why I thought it was important for us to hear this side of the story in this committee in some detail. If you want to hear the other side, I would invite you to log in and find where licensing and occupation has covered this in multiple years in the past, repeatedly. And one side has been heard, another has not. So I would encourage you to go back and watch those if you want to hear the side of the case on the other side of it. Next, I have Senator
Chairman.
Meredith.
Thank you, Chairman Alvarado. And it's like, here we go again. I think your points are well taken about this has been heard numerous times in licensed occupation. It should be. What's the focus of this committee? What should it be? It's improve the health of our population. I think we lose sight of that. You know, whenever there's a void in the vacuum, it's going to be filled by something. And I think we got to ask ourselves, well, how did we get here? Well, obviously there was a void. And back when I started in the business, you principally had physicians and nurses. That was pretty much a healthcare delivery team, and it's expanded since then to try to address that void. And I think this has been a natural progression of that. That's the way a capitalist system works. If you have a demand, then somebody steps up to meet that demand, try to adjust the supply in various ways. And I think this is just truly a natural progression of an economic model. But I think it's interesting that even with all the things that we have done in the changing scope and practice, we haven't improved the health of the state significantly over the last decade. And I thought it was most interesting, Dr. Bailey's comment that even with the growth in the number of mid-level practitioners, principally physician assistants and nurse practitioners, that we're still not seeing those people practice in rural communities. And to use a medical metaphor here, I get tired of treating the symptoms and not curing the disease, and the disease is access to care. And why don't we ask the fundamental question of why won't physicians, nurse practitioners, any healthcare professional choose to practice in a rural community? And I've given this speech before, because it's not an equitable system. When I talk to our insurance partners, they say we pay everybody the same equally. No, you don't. It's an equitable system. It builds on itself. And even all these things we're doing, it still hasn't changed the outcome, particularly for rural Kentucky, or is noted in some of our urban areas. The challenge is poverty. We spent a great deal of time and resources the last couple of years fighting COVID, which is quite appropriate. But what results from poverty is much more devastating to our society than even COVID, and we don't make that same concentrated effort on that. And to me, it starts with treating these healthcare deserts equitably. And it's not going to happen until we recognize that. And this should be an economic model as well, that if you can't get people to go to an area, what do you have to do? You have to entice them by giving them more pay. I asked a question in our managed care organization, or our Medicaid oversight meeting the other day, the MCOs, why won't physicians go to rural communities when they know they're going to be making 25 to 30% less than their urban counterparts? They're going to have a more critically ill population, a less compliant population. Why would anybody go there? And quite sure they didn't have an answer for me other than, well, some people kind of feel it's a mission to do this sort of work. I appreciate that and I embrace that, but it doesn't address the fundamental issue that if you want people to go to rural communities and we want to improve the health of the population, we should be paying those people more, not less. It doesn't cost any more because we're going to save tremendous amounts of money by improving the health of our population. But here we are again talking about scope of practice, which is not going to improve the access to care whatsoever. This is coming on my sixth session here in the General Assembly. In every session we have talked about this, and you noted that states deal with this as well. That's the wrong thing to focus upon. And I assume that this session we're going to have more bills about the scope of practice. My fundamental question is, what's the end game of this? What are we trying to accomplish other than self-protectionism from everybody, which just doesn't advance our cause whatsoever? There's got to be a different way to do this, a better way to do this. We're not hitting on that. I think we got to focus on access to care, true access to care for everyone, and be fair about it, and we're not at all. So I really don't know where this thing is going. We can continue to broaden the scope of practices, which we've done ever since I've been here, for everybody, but it's not improving healthcare outcomes. It's not improving access to care. So what's the end game here? How much longer are we going to continue to do this? And quite truthfully, I like this team-based care concept. That's great in theory, but if you don't have a physician in your community, it falls apart. And I think that's part of this natural progression is if you don't have a physician there, who steps up to fill that role? And I think the nurse practitioners have had to do that in rural communities. So when they've had that experience, then they start to ask themselves, well, why shouldn't I be able to do these other things as well? I think it's a fair question. But quite candidly, I don't mean this critical of them. It's every profession, they don't know what they don't know. So they can't determine their limitations. I guess that falls back to us. But again, I want to know, what's the end game of this thing? How are we going to address this? And what does scope of practice truly mean if it's not directed upon improving access to care? I don't care about people protecting their turf. It's what's the end game? How are we going to address this?
If I may comment on that, I think Senator Meredith hits a lot of nails directly on the head. Oftentimes, the strategy is, again, we use the phrase access to care. And if I had a nickel for every time I've heard it, sometimes legitimately, sometimes as a marketing tool, but I would be on a beach, not here, enjoying myself in retirement if I had a nickel for every time I've heard it. And so I think the biggest point out of what Senator Meredith is saying, and I think I have full confidence that the Kentucky Medical Association stands behind the statement of access to care will be accomplished, legitimate access to care will be accomplished when we have all providers in all areas of the state. And again, I told you in my opening comments, if you took nothing else away from what we said, we want a team-based care model because it is happening. It happens to the providers that you go see. Oftentimes, many of you have said, well, you know, I love my PA, I love my APRN, I love my doc, but it's crowded in there. And so it looks like they're really working hard together to take care of their patients. And that is absolutely, positively correct. And that's the workable model. That's the right model. And so if we have nurse practitioners out in the rural areas and not physicians, it won't work. If we have PAs out in rural areas and not physicians, it won't work. Quite frankly, if we have physicians out there without help from nurse practitioners and PAs, it won't work. So the answer is true access to care where they have those providers all available. Our point here is not to, oftentimes we hear that don't talk about education and training because that diminishes other groups. And so for many years, we have stayed away from that talking point. I'm going to be honest with you. Because physicians don't want, at least my members that I talk to, they don't want to have that reputation. They want us to say how much nurse practitioners and PAs are valued. But when it comes to facts and why we need to build the team, and in our opinion, who needs to lead that team, we have to draw some distinctions so that we know who is leading the team and who should lead the team based on education, training, experience. But that doesn't mean doctors know how to be nurses or nurse practitioners or PAs. They all are uniquely educated and trained to accomplish a purpose. And when we put them together, and hopefully when we put them together, meaning with assistance from the General Assembly, we will then see better health outcomes. That's what we mean, and I think that's what's going to do it. And if that means incentives to get not just physicians out in underserved areas, let's call it underserved areas, that encompasses both urban and rural areas that have needs, to get not just physicians there, but all providers there, I think that's when we're going to see a true turnaround. But that's difficult, right? Oftentimes when we talk about incentives, we talk about money. And certainly in a cash-strapped state, that's tough to come up with at times. So oftentimes it's easier to say, hey, we're going to work on the access by removing this restriction from this group or that group. But to Senator Meredith's point, by this point he probably could be a doctor, but to his point, it hasn't worked. For 25 years, there's been various groups looking at changing the scope laws, and we come back every single year and say, oh, well, just give us this one more thing, and that'll solve the problem. And then we're back the next year, KMA having to come up and express concerns, other groups saying, well, let us do this or let us do that. It's well-intended maybe, but it's a model that just simply is not working.
Mr. Chair, I think his points were well taken, but in the 5 years that I've been here, I think we've tried to be as accommodating as we possibly can be to everybody, and it hasn't made a difference. And we still have the issue of access to care both in rural and urban areas. personally, I'm to the point I wish we would just put a stay on this whole discussion and really focus on the core problem, which is access to care, true access to care. And I think it goes back to the payment methodology and the delivery model that we use. You know, hand in hand with this, we know that 60-70% of healthcare problems are based on social determinants, but yet we never address those social determinants because we say there's not enough money. I'm telling you, there's enough money in the system to solve these problems if we spend it the right way, but we don't. We don't, ever. So how much longer are we going to continue this financial death spiral, which is going to be, because now we're getting 20% of our gross national product is on healthcare. If it hits 25%, this economy is going to collapse. Not only that, but the health of the population is going to get worse and worse, and we haven't accomplished anything. It's time to have a reset on this whole process, or we're going to fail. Everybody is. We won't be worrying about scope of practice. We'll be worrying how we're going to feed ourselves. Thank you, Mr. Chair.
Thank you, Senator. So I've got about 7 or 8 people who've just started raising their fingers and want to talk, and we've got about an hour left in the committee, and we've got 2 other groups of presenters. So I'm going to try to go about 5 more minutes on this topic. The next person I've got is Senator Adams.
Thank you, Mr. Chairman. And I guess my question would be directed to Dr. Bailey. Based upon your slides, you talk about the benefits of being a physician-led, team-based care model. That's what we're all striving for, a physician-led, team-based model. Would you consider Kentucky to be that model? Where'd you go?
She's on mute.
I think you're muted.
You're muted.
Thank you. There was a car horn going off in the parking lot. I think Kentucky has done a good job. Many states, including Kentucky, have seen the importance of patient safety in terms of having physician-led care, physician-led teams.
Okay, because I would believe that based on our system, I would agree with you that we currently are a physician-led, team-based kind of approach. But you also mentioned in your comments about the overprescribing of opioids, the increased cost of care because of diagnostics, what else? Referrals out. If we are currently in a physician-led, team-based approach, all of those things happen under the direct care of a physician. So the increased costs are not on the ancillary groups. It would be under the purview of the physician. Am I correct?
Not necessarily. The data that I mentioned included states that where nurse practitioners and physician assistants have full prescribing authority, and so so much of the data pertain to that, and of course much of this is multifactorial, but the fact of the matter is that physician prescribing of opioids has gone down consistently in the last few years, and we're not seeing the same for nurse practitioners and physician assistants.
Okay, but I will remind you that a nurse practitioner cannot write a prescription without a physician's authorization.
Currently in Kentucky, yes, but in other states they can.
Okay, but again, we're talking specifically Kentucky. And so if you're extrapolating data and giving us, I guess, a snapshot of what you portray Kentucky to be, your data is not accurate portrayal of what is happening in our state. And so, I just want to be clear that I think some of the assumptions that are made are not Kentucky specific. Thank you, Mr. Chairman.
Thank you, Senator. I remind everybody that we've suspended the Kappa CS rules for physician supervision for the last 2 years. So we'll have an opportunity to look at that data in the upcoming year because that rule has been suspended by the General Assembly in light of COVID. So there has been no physician supervision in that regard. It might be a good point for us to talk about independent nurse practitioners or independent practitioners in the state. Perhaps, Mr. Meadows, you could expand on that a little bit because I think people think that they're somehow fully dependent on physicians. It only comes down to the Kappa CS model we've talked about with prescribing of narcotics. Maybe you can talk about the ability for a nurse practitioner to practice independently in the state, refer independently in the state, see patients independently in the state, prescribe other medications independently in the state. Maybe you can go into that in some detail.
Well, other than to echo what you just said, which I think is absolutely accurate, in Kentucky, and I do think there's a disconnect oftentimes, and I'll hear this from physicians too. When I speak to them, it's oftentimes the assumption is that nurse practitioners must work for a physician, are directly supervised by a physician. There is a difference between the definition of supervision, and there's even varying degrees of what supervision means. Sometimes it's direct, like right over the shoulder. Sometimes it's supervision where you are responsible for that practitioner, but you can be located down the street, but as long as they can get a hold of you by the phone or some communication method, then that's still supervision, but it's a little more relaxed. But there's a big difference between supervision and even collaboration. And then there's certainly a big difference between supervision, collaboration, and full independence. And in Kentucky, what we have is physician assistants they're supervised by physicians. They're actually regulated by the Kentucky Board of Medical Licensure. Just like physicians. Athletic trainers are supervised by physicians. They are regulated by the Kentucky Board of Medical Licensure. Nurse practitioners are different in that they are regulated by the Kentucky Board of Nursing. And so even though you've got practitioner groups doing virtually the same thing, you have different regulatory boards. And so in Kentucky, by law, nurse practitioners are, I would say, independent practitioners with a caveat. And the caveat is that, first, they can, what independence means is they can treat, they can diagnose, and they can prescribe. The only caveat is that with prescribing, they are required by state law to have a collaborative agreement. Notice I didn't say supervisory agreement, collaborative agreement with a physician when it comes to prescribing both non-scheduled and scheduled drugs. And the more recent conversation has been about scheduled drugs. We're talking about controlled substances there. We're not talking about Z-Paks and high blood pressure medications, cholesterol. We're talking about Xanax, OxyContin, hydrocodone, those types of things. And so by law, they have to enter into a written agreement with a physician when doing prescribing. Does that mean that they have to be somewhere close to a physician? No, not at all. Right now, and this is the other thing that we oftentimes get into, is we talk about unmet needs, whether it's in underserved areas in the city or in the rural parts. There's nothing that prohibits a nurse practitioner currently from going out in Hindman, Kentucky, to use Knott County as an example, to set up a practice. Again, they're independent. They're regulated by the Board of Nursing. It's just that if they're going to prescribe controlled substances, again, those drugs that I mentioned, they enter into a collaborative agreement with a physician. And what is that meant to do? Just briefly, I know we're running out of time, Mr. Chair, but what that is meant to do is not for necessarily the doctor to tell a nurse practitioner, you must do this or you must not do that. It really is meant to be an agreement to where they work together. That's collaboration. That's why it's collaboration and not supervision. If it's a supervision agreement, the physician would probably have more say. But it's supposed to be a two-way dialogue to where they enter into it on some of the most habit-forming, let's face it, dangerous drugs, to where it's supposed to be a mutual benefit for both, to be quite honest, because physicians are not perfect in prescribing. And so it really is meant to be a two-way communication where they collaborate, they meet, they talk throughout the year, and they assist each other when it comes to prescribing those types of drugs. I hope that gives a little bit more background about what Kappa CS is when we say that.
Thank you very much. I'm going to take one more question. Dr. Berg, I don't know if you're online. I think question, and then we're going to need to move on to the next presentation.
I am. Can you hear me?
Yes.
Thank you, Chairman Alvarado. And my question is specifically for Dr. Bailey. Thank you very much for your presentation. I have very much enjoyed hearing it. I have a very, I think, simple and direct question. In your opinion, does our current collaborative agreement requirements in Kentucky meet the definition of a physician-led team? And let me clarify that a little bit. My understanding of these collaborative agreements, which I've looked into them a good bit, is, the nurse practitioner is required to pay a physician. into a collaborative agreement. But what I can't find on the other side is any responsibility of that physician. There's no, I can't find where it says you have to do a monthly review, that you have to be available on call, that you have to do a semi-annual review, an annual review, that you have to do anything in writing. I can't find what the responsibility of this physician is. So for me, as a practicing physician who works in physician-led teams in the hospital, I mean, you have to have a responsibility. You have to have a role. You can't just remotely far away from where nobody can reach you when they have a question and need you. Consider yourself collaborative. So what is your, when you say a physician-led team, what is, how do you see that? How do you envision that?
Thank you for that question. I envision a physician-led team, even though they may not all be in the same, physical location, to be where the physician holds the ultimate responsibility for that patient's care. And with the definition, my understanding of how things work in Kentucky, and I confess that I'm not an expert on that. It does sound like a physician-led care team model. Although, no model is perfect. Every model can improve. And I'm not an expert on the roles of the supervision for physicians in Kentucky, so I can't really answer that part.
And I'll be happy to jump in here. There's not a requirement for a doctor to be paid. I supervise nurse practitioners that I'm not required to be paid to supervise them. There is a regulation that deals with this. Our staff is getting that for you, Dr. Berg. We're going to forward you the regulation that provides what physicians are required to do. But it sounds like you might be open to the idea of perhaps passing some kind of legislation to tighten those requirements for physicians who supervise nurse practitioners. And if you have that, I've filed that bill before, and I would welcome that. All right, well, we've got to move on. I appreciate all the presenters. I know there's others that have questions. I've got several people that want to ask them. This probably could go on for another hour and a half, but we do have other presenters here, and in light of their time, I want to go ahead and get to the next presentation. If others, hopefully, Dr. Bailey, if you'd be available, or if others might be willing to, after all the presentations are done, some of the folks who have questions could ask that of Mr. Meadows and yourself if you're willing to hang out and listen to our other presentation. I thank you all for coming today and for the information. This is always a hot topic, one with a lot of passion on all sides. So, and again, I share in that, and I appreciate you all presenting information on this side of it. The next item on the agenda is liability reform. We've got today several presenters here. We have a Partnership for Common Sense Justice. We have Jim Musser, the Vice President for Policy and Government Relations for the Kentucky Hospital Association, and also the Chairman for Partnership or PCJ as we know it. I believe we have also Kate Shanks. I know Ashley wasn't able to join us today, so Kate Shanks is representing the Chamber of Commerce. We have Nathan Morris, Vice President of Legislative Affairs from the United States Chamber Institute for Legal Reform. And I believe, Mr. Meadows, you're going to be hanging out also to talk about, as again, Director of Advocacy for the Kentucky Medical Association. You guys are getting your presentation put together. Whoever is ready, if you'd like to introduce yourselves for the record officially and begin your testimony whenever you're ready.
Good afternoon. I'm Jim Musser. I am the Vice President for Policy and Government Relations with the Kentucky Hospital Association and currently acting as Chair of the Partnership for Common Sense Justice. Thank you, Dr. Alvarado, for having us. Thank you, Chairwoman Mosier. And as this is Thanksgiving week, I would like to say just a couple of other thank yous. I would like to thank Dr. Bentley for all the work that he did in the last session and the session before for our rural hospitals on the Rural Loan Program. And I'd like to say a very sincere thanks to Representative Frazier for the work that she did on telehealth. Both of those have been so important for our patients to receive the kind of care. And thank you to all of you for being so good at being stewards of the health care of our people. As I often say to you, your constituents and our patients are the same people, and we want the same good outcomes for them. So, with that said, our topic today really is liability reform, and who is the Partnership for Common Sense Justice? The partnership is an organization with membership representing virtually every industry and every walk of life in our society. The Kentucky Hospital Association is honored to act as chair for the next 2 years, and we inherit this mantle from our very able friends at the KMA, and we appreciate the leadership from the chamber that they have provided. Our liability system in Kentucky imposes lots of costs on people, and we think that that needs to be addressed. Going to Senator Meredith's point about addressing the social determinants of health, there are costs imposed by our liability system that really can be corrected. What you should know when we talk about liability reform, it's not a code for radical change. It's not put plaintiffs' attorneys out of business. 40 other states have already enacted liability reforms, and there's access to the courts, and we support access to the courts. Everybody should have access to the criminal justice system and to the civil justice system, and we are not at all opposed to that. But problems have arisen over the term of a number of years, and the current system really does drive healthcare costs. And it's not just healthcare costs, it's costs for every business in our Commonwealth. But the healthcare costs from my KHA hat, we're seeing increasing insurance premiums every year. Providers are concerned more and more about paying insurance premiums and protecting themselves from lawsuits. And it becomes very easy for a provider to say, do I settle in Louisville, or do I put my new practice in Indiana where there's liability reform and the insurance is so much less? And it's an easy choice for so many of them. Unfortunately, it's an important choice that too many of them make and say, I'll go to Indiana, or I'll go to Tennessee, or I'll go to some other state that doesn't have the unpredictability that's been built into our system. And again, this isn't because of plaintiffs' attorneys. Plaintiffs' attorneys follow the rules that have been put into place over the years. And we've kind of developed this sort of wheel of justice system that too many people look at and they think, oh, this is the way to become a millionaire. And they think that this is the thing to do because they see advertisements on TV. We are the fortunate heirs of Anglo-Saxon jurisprudence, which says someone who's been hurt should be put back in as good a position as they were before they were injured. Not more than that. That is what they are supposed to have. So how did we get where we are? How is it that we got to this system that's so unpredictable and that so pushes the costs? Dr. Alvarado, and I know Dr. Berg, you know this, you're pushed into practicing defensive medicine, and that raises the cost for your patients. The patients, your constituents, they're facing that increasing cost. So where we've come from and how we got here is because the courts over time have arrogated powers to themselves that rightly do belong to the legislative branch. And we think that the right step to take is rebalancing that. The founders made it quite clear. The founders wanted 3 co-equal branches of government, but if you look at the Constitution, the first among the equals is the legislative branch. You are the voice of the people. And unfortunately, the voice of the people has been repeatedly thwarted by a court system that down through the years has taken more and more power onto itself. And whether it was Democrats in charge or whether it was Republicans in charge, you've passed liability reforms that the court system has struck down, not based on plain language in the Constitution, but based on interpretations that have come down through the years. So the time really is ripe for us to rebalance that, for the legislature to reassert its role in determining what the liability system is supposed to look like in this state. And we're looking forward to working with you on that because, as Senator Meredith points out, the way to address the social determinants of health is to have a wealthier society. Health and wealth are inextricably intertwined. There is no separating them. And the only way to have a wealthier society is to make sure that businesses find the liability system here attractive. It's part of a business climate that needs to be welcoming. It's part of a business climate that says everyone deserves access to the courts. All litigants should be treated the same way. Everybody should have their fair day in court, but we're not doing this to make people rich. We're doing this to make things just. So we're looking forward to you working with us, and you can see the list of groups that are involved with the partnership, and it really does represent every walk of life in our society. We think that the time is right, and we're looking forward to working with all of you on legislation to make sure that we're rebalancing things the way that they need to be rebalanced. We think that there are plenty of steps that you can take to reclaim your power. And again, thank you. Thank you for having us today, and thank you for all of the work that you do on behalf of our patients and your constituents trying to make us a healthier state.
And I'm Kate Shanks. I'm Senior Vice President of Public Affairs for the Kentucky Chamber, and we're happy to join our colleagues at the Hospital Association, the Medical Association, talking about this topic. And I think when you think about liability reform issues, you automatically think medical, but we look at this from a broad-based business perspective. And I know, Chair Alvarado, we've worked with you on legislation involving caps on non-economic damages. We've worked, Chair Moser, with you on the attorney advertising legislation, and with you as well, Senator Alvarado, on that legislation. So this is something we've worked on for quite some time. But when COVID-19 hit, it really shined a bright light on the underlying concerns of business leaders when it comes to liability. We saw it firsthand. We would hold webinars with some of our attorneys just to help answer questions that business leaders might have. They were always incredibly well attended. We answered questions from so many business leaders just wanting to understand the new regulations that were placed on them to control COVID, wanting to do everything they could to protect their employees, dealing with an uncertain virus that they had never dealt with before, along with new rules that they had never dealt with before. How do I keep track of employees' temperatures, for example? And so we really worked hand in hand with so many different business leaders across the state in trying to help them mitigate the risk of this virus. And it really brought to light so many different concerns about liability. And I want to pause and thank you for passing Senate Bill 5 during the 2021 legislative session and then extending it again during the special session. And on the screen are all the different groups, businesses, associations, local chambers that signed on in support, because this legislation was so important into clarifying protections for the many business leaders that did their part to stop the spread of the virus. And it sent a strong message to the business community, and my colleague Nate is going to tell you a little bit about why that matters, that you are absolutely going to protect and defend these business leaders and these places where people worked and visited, because they had done so much to stop the spread of the virus. So I do want to thank you for that. We come at this issue through the lens of competitiveness. And so I've asked my colleague Nate Morris to join us with the U.S. Chamber, and I'll let him introduce himself for the record as well, because they have a really great perspective on those issues across the states. And he can kind of help us understand where we are and where we can go. And I'd like to, Chair, turn it over to him to give just a few comments as well.
Okay. Well, Chairman and members, thank you for the opportunity to be with you to discuss the importance of Kentucky's legal climate. As Kate mentioned, I'm Nate Morris. I'm the Vice President of Legislative Affairs for the U.S. Chamber's Institute for Legal Reform. And if you'll indulge me, since we don't testify here very often, the U.S. Chamber of Commerce directly represents over 300,000 members, including many, many businesses from Kentucky. We also represent, through partnerships with great organizations like the Kentucky Chamber, millions of members across the country. ILR is a division of the U.S. Chamber of Commerce, and our mission is to advocate for a fair legal system that promotes economic growth and opportunity. As part of that mission, ILR raises public awareness of legal issues, and we urge policymakers to effect positive change to improve your state's legal climates. We also have a research team that publishes white papers on legal issues and explores the economic and other impacts of litigation. One of our recurring research products is a ranking of states' legal climates, and those rankings are based on senior in-house attorneys' perceptions of states' legal climates. Experienced attorneys are asked to evaluate different features of legal systems, such as how states handle scientific and technical evidence, for example. Kentucky ranked 40th in our most recent survey. That was in 2019, shortly before the pandemic. And that was a modest improvement from Kentucky's ranking in 2017 when it was 42nd. Looking further back, and I think we have a slide on this, which may not be the most informative slide we've ever presented, but the legal climate here has been on a downward trajectory. You ranked in the mid-30s through the early 2000s, which aren't shown here, and peaked in 2008 at 29th in the country, so squarely in the middle of the legal climate pack. But you've been flirting with the bottom 10 ever since. And my message today is a very simple one. Your state's legal climate matters, and it can be improved. Companies that are making important business decisions, like where to invest or grow, consider legal climates when they make those decisions. They're looking for legal climates that are fair and that are predictable. In our last survey, a record number of respondents, 89%, reported that important decisions are impacted by a state's legal climate. But your legal climate doesn't just influence decisions about the future. It has a very real and very current effect on businesses and Kentucky families. In 2018, can we skip ahead? Thank you. I should know how to work this myself. In 2018, ILR released an economic study that quantified the total cost of the tort system in the United States. We were able to break that number down state by state. As this slide shows, tort costs and compensation are equal to about 2.3% each year of Kentucky's gross domestic product. That's higher than many of your neighbors. We have several listed here. North Carolina, Virginia, Ohio, Indiana are all lower. They're all under 2%. And that may seem like a small difference, 2.3, 1.8, it's only half a percentage, but that ends up to tens of millions of dollars a year in additional costs in Kentucky. And what those higher costs translate to for Kentucky families is about $2,600 per year in tort costs, if you kind of average those costs across all the family units and households in Kentucky. Put another way, that's a bit more than 6% of a median household in Kentucky's annual income, which means that your tort system costs the median family in Kentucky more than your state income tax. We also know that legal system costs hit small businesses especially hard. We released a separate study last year that shows businesses with under $10 million in annual revenue bear about 53% of the cost of commercial liability. That's 2.5 times their revenue share, as they bring about 19% of business revenue nationally. For the smallest businesses, those that bring in under $1 million annually in revenue, tort costs are 10 times higher than they are for large businesses as a fraction of revenue. That's a lot of numbers, but the point I'm trying to make is a really simple one. As I travel the country, I'm sometimes told that legal climate issues are a big business problem. That's just not true. It's an all business problem, and it's especially a pronounced small business problem. We've heard about medical providers, quintessential small businesses. Kate mentioned SB 5 and the broad coalition there, and I think what the interest in COVID liability shows is that it's not a business problem exclusively. It's a healthcare problem, an education system problem, and even a problem for charities and religious institutions. I don't have a slide for this, but I do want to take a minute to talk about how acting to improve your legal system worked in recent history, touch on a few things that could be done to strengthen it in the future. On the impact of reforms, Kentucky was an early mover on COVID liability issues. You were among the first states in the country to address healthcare provider liability and liability for products used as COVID countermeasures. Then you circled back and passed SB 5 to address exposure issues. And so I had the research team go back and pull some numbers on this before I came down. And over the course of the pandemic, Kentucky's year-over-year GDP growth, which was slightly below the national average pre-pandemic, dropped less and bounced back faster than the national norm. Looking at unemployment data, you see the exact same story. Pre-pandemic, unemployment in Kentucky was higher than the national average. During the pandemic, especially after SB 5, more folks in Kentucky kept their jobs, and workers who lost their jobs were back to work faster than average across the country. Small businesses in Kentucky saw less revenue drop-off than their national peers, and as a result, more were able to stay open over the course of the pandemic. So, correlation's not causation. I don't want to make a specific claim as to cause, but I think it's reasonable to say that Kentucky's prompt action on COVID liability helped the state fare better than many of your peers over the last 18 months. And that's a success story that you can build on. We produce a comprehensive guidebook on how to improve legal climates, 101 ways to improve state legal systems. I'd be happy to provide every member with a copy. That covers more issues than would be possible to talk about here today, but forum shopping, jury diversity, evidence rules, calculation of medical damages, guardrails for class and mass actions, controls for punitive and non-economic damages, and lots more. in addition to the things that are laid out in the 101 Ways primer, and the issues that have been discussed here today about medical liability specifically, I'd suggest the legislature take a close look at legal services advertising. Lawyers can advertise their services. That's a given. They have a right to do that. But some ads are misleading, and they're styled as public service announcements or medical alerts. Or they describe medications prescribed by doctors as dangerous or unsafe in ways that scare consumers who respond by discontinuing medications. Sometimes that has life-altering and sometimes, very sadly, life-ending consequences. Rep. Mosier had a great bill on this issue a couple years ago. It's only grown in importance, and we'd urge you to take a fresh look at that piece of legislation. Second, large-scale investors are putting a lot of money into lawsuits. A Bloomberg article from earlier this month reported that the so-called litigation finance industry has grown to about $39 billion. Parties and juries and judges, especially judges, we think should know if a New York-based hedge fund is staking a Kentucky lawsuit. We also believe that they should be liable for fees, costs, and sanctions that are assessed if they stake a bad case. Finally, I'd echo others' suggestion. I think Kate suggested this explicitly, but if she didn't, I will, that SB 5 should be extended. Businesses are confronting a lot of challenges today, COVID, supply chain issues, inflation, worker shortages. If SB 5 expires as it's set to in January, that's another serious challenge they'll have to confront that they probably don't need right now. So thank you for the opportunity to speak with you today. I'd be pleased to answer any questions you have to the best of my ability.
And then finally, for the record, my name is Corey Meadows, Deputy Executive Vice President and Director of Advocacy for the KMA. I appreciate the opportunity to speak to you further today on this particular topic. And I would also like to echo the general sentiments of everyone who has spoken thus far, but in the interest of time, I'm not necessarily going to repeat everything that they have said. However, I do think one item is certainly worth repeating, and that is the profound appreciation for the passage and the reauthorization of Senate Bill 5 and its provisions. And we also strongly urge the General Assembly to pass those provisions again. Your actions protected physicians and nurse practitioners and PAs. This is an issue of common interest, and it really did protect those healthcare providers who rose to the challenge and hardships caused by the COVID-19 pandemic. With that said, the passage of Senate Bill 5 should not necessarily distract us from the fact that Kentucky's liability system is fundamentally broken, and it needs to be fixed to ensure greater fairness and predictability within our legal system. The medical liability system remains one of the most vexing issues for Kentucky physicians and healthcare providers today. It actually places a wedge, oftentimes, between physicians and healthcare providers and their patients. It forces physicians to unfortunately practice defensive medicine, which is very hard to quantify. Many studies have been done on that, and the numbers are large, even at the most conservative estimates. But that's the wedge that it places between providers and their patients, and it costs our healthcare system an untold amount of money every year. It puts physicians at emotional, reputational, and financial risk as well. I can offer you an example. I know we're pressed for time a little bit, but anytime you're interested, I can offer you some national statistics about how often and the frequency in which physicians are sued during their career. And it's mind-blowing how often they face at least one lawsuit, and some of our more high-risk providers like general surgeons and OBGYNs actually face that at an even greater rate. I will also say that a broken liability system can negatively impact physician supply. And let me add to that, in light of the earlier conversation, the overall healthcare provider supply. And that leads, obviously, to less patient access. We know the reason that it affects supplies is because we know that the liability system affects not only how physicians and healthcare providers practice, but where they practice as well. And so if you go to a climate or where liability concerns are high, you're less likely to find people who actually want to locate and live there. It's an economic development issue as well, which I think has obviously been covered, but it is worth saying that every area of the country is in competition for providers and infrastructure needed to support a healthy workforce. How many times have we heard that we need a healthy workforce in order to prosper economically? Jobs follow good medical care, As any employer looks to where to locate their company, it looks at many factors, but clearly at the top of the list is a strong healthcare community to support its workforce, and that's clearly one of the reasons why we sit alongside the Chamber of Commerce in supporting medical liability reforms. Medical liability premiums also continue to be an enormous expense for physicians and the entire medical industry. Premiums differ by state, and because they differ by state, that can influence where a physician decides to locate their practice. And now we know that medical liability insurance premiums have begun an upward trend after holding more or less steady during the past decade. And this is according to new analysis from the AMA. And that may sound familiar because I brought this point up as a part of a provider shortage back in September. And so, again, got some statistics to go along with that. If you're interested in that, I'm happy to repeat them. But just know that the evidence is showing that the medical liability premiums are on the rise. Now, with that said, even though we're spurring action, I think Jim mentioned this. The Kentucky General Assembly has acted before. It goes back decades. Omnibus packages in the 70s and the 80s. And on multiple occasions, liability reforms have been repeatedly struck down by the courts based on their interpretation of the state constitution. And as a result, the state constitution should be amended. And I pause there to emphasize that point, to provide the legislature, you, the people's representatives, greater latitude to determine what reforms are needed or not needed. And those are decisions that should rely with you. Again, it's been a pleasure to speak to you today about this important issue, and I'm happy to answer any questions that you have.
Thank you all very much and appreciate your information. I think everybody knows I'm pretty passionate about this issue. One of the main reasons I'm serving in the General Assembly. As a practitioner, I know I can give lots of stories of patients that homeless who get readmitted to the hospital time and time and time again and go 62 CAT scans in 1 year. Radiation of a year's worth of sun exposure is equivalent in one CAT scan. Imagine having 62 years worth in 1 year. Why? For fear of I might miss something, I better go ahead and repeat it just in case. And that's what we've been training our physicians, residents, lots of people in healthcare to do. And it's really feared out of lawsuit driven. And you get trained on that very early on, and that's kind of how the mentality is. It isn't necessarily an academic approach. I do have a few questions before we go into questions from members. And I want to let members know I file every year. It's almost like for me, one of the, people complain about the bills I file, but I'm going to file a constitutional amendment again this year to change this. We've had an opportunity to pass plenty of bills, and I'm tired of the judicial branch thinking that they have more authority on this issue than the legislature does. And I think it's time for us to change that, to give ourselves the authority to start making changes in our own laws. Right now, it's being held hostage, in my opinion, and there have been, bills passed by both sides of the aisle for decades, as has been testified on this topic. And I think we're also going to be seeing another bill on truth in advertising that either Chairwoman Mosier or myself will be running this year as well to bring that back. I've had patients who've stopped anticoagulants, who have suffered strokes and death because of advertisements on television, thinking, well, we thought that the FDA said something, so they were fearful and stopped it. And really, it was a legal advertisement by a law firm looking for lawsuits. A couple of questions for our presenters, and I'm not sure who might be able to answer that. How do we rank in terms of lawsuits per capita? I know that our rankings, from what I understood, one time we were top 5, I think, in lawsuits per capita. Do we have any data on that?
And I became a lawyer, so I didn't have to do math. I don't have that number in front of me, but we'd be happy to get it for you.
That'd be great. I mean, do we have any idea how we rank on contingency fees in particular? I know when I've filed bills before to limit that in this state, I've had colleagues of mine in the legislature who are lawyers who didn't believe the amount of contingency fees that are being used by some attorneys. And when they went to their bar association, confirmed that it was between 40 to 45% on some cases. Do we have any idea of where we rank in this state?
So because the fees are an agreement between the plaintiff and the client, that's not something that's disclosed in the normal course of business. We have a sense of what that is nationally. 50% would be quite high. Different firms will handle this different ways. Normal is between 30 and 35%. And then there's a question as to whether it's inclusive or exclusive of fees and expense of filing fees, copying fees, et cetera. I've seen cases where folks end up getting almost nothing with small dollar claims because they paid so much in filing and copying fees, for example. So how the fee is structured is important too. I would say I raised the issue of litigation finance. One of the reasons contingency fees exist is because in theory, attorneys are taking a risk onto themselves by taking those cases. If they've got outside investors financing the case, they've de-risked the case. That's the entire business proposition for the funders. We remove your risk. So I think there's a fair question about who's bearing risk and whether all of the costs there should be borne by a plaintiff if a funder is taking a cut and the lawyer is taking a contingency.
Another topic that I often get, people that argue against this say, well, this is not really a problem, that we really don't have that many, there aren't the lawsuits that are out there. This doesn't really exist. And I always struggle to get insurance data from the insurance companies who defend these. Most people that have these don't want to disclose it for fear of their reputation being tarnished about how many lawsuits. We know that maybe someone can describe the process of how this goes, that often it's demand letters. And when I talk to providers, and I've reviewed cases that have no merit, only to find them have settled the case. I go, why? There was no merit. Well, frankly, if we fought this in court, it'll cost us $400,000 in legal fees and to clear our name, or we can pay basically an extortion fee of $100,000 and they go away. And that's been the model we've had in this state for a very long time now. And I hear it over and over and over again. Someone can go through the process of how this works right now, because what I'm getting on the counter is these aren't lawsuits that are really being filed. Show us the numbers, show the data. And I think it's either the demand letter or something comes prior to that. If somebody can enlighten us as to how that occurs.
It's been a few years since I practiced in the civil arena, but Dr. Alvarado, you described very well kind of the overall general process. Typically, what most people don't see is that pre-litigation process. Oftentimes we think about, well, lawsuit is immediately filed, they head straight to court, it's over in a matter of months. Quite the contrary. The pre-litigation phase goes on for quite a long time, and that's whether or not the case ultimately reaches a trial verdict or not. In fact, most of the time, a trial by jury and a verdict is never given because it's settled long before that. But it will typically, and I'll defer to our attorneys on the committee as well, but it normally one of the first processes that you'll see is that demand letter. Ultimately, it's an attorney sending an individual or a liability carrier or someone a letter basically saying, we believe that malpractice has been committed and therefore we are thereby wanting to settle this very quickly up front for this requested amount. Oftentimes, those are rejected, and that enters into a negotiation period where the parties come together, and ultimately, if they can't reach some sort of an early settlement, then they go into that more involved pre-litigation process to where records are gathered, depositions are given, a lot of what they call interrogatories are submitted and answered. It is a very time-consuming process, and I point that out because it can be very, very expensive. And so in my comments, when I reference the emotional toll or the financial toll that it can take on, in KMA's purview, a physician, that is extremely a heavy burden on physicians. That can last anywhere from, it can last years, but it doesn't usually get resolved very quickly. It drags out for many, many years. I know one particular physician who's actively involved in KMA who had a civil case go on for 10 years. 10 years that hung over that provider's head, going to various depositions, going through the various processes. Ultimately, he did not settle, and it went to trial. It's one of the rare few that actually went to trial, and he won. But what kind of congratulations do you get when you've been in it 10 years and that kind of money and that kind of time, that dark cloud is hanging over your head? How does that even affect your patient care? So it is a real issue. That is a more long and drawn-out process. Now, I want to be clear that we're not saying that people who have legitimate claims due to medical malpractice or what have you don't deserve their day in court. That's the foundation of our civil justice system, and it should be recognized. What we're asking for is not special advantage. We're asking to level that playing field because some states do it better than others, and we feel like that we can do much better in the Commonwealth.
Thank you. And obviously people that have been wronged who have to wait 10 years also, it's a toll on that person and that plaintiff as well. I mean, to argue the other side of it as well, I mean, it's a toll on everybody. It's a system that's broken in this state. That it takes a long time to get things done, and it's very expensive. Okay, I've taken up enough time. I've got 5 members who have questions. Representative Birch.
I got a couple two-pronged questions, I guess it is. One, if you're proposing this legislation, it's going to include not just doctors, right? It's all medical, and then it could go over into other businesses. We're changing the Constitution. Is that correct?
There's various proposals that have been offered. There have been constitutional amendments offered. There's been smaller initiatives offered, like medical review panels a few years ago that we were successful, in helping the General Assembly enact. Ultimately, it went to the Supreme Court, but because of the way our courts interpret our current state constitution, they struck down that law. And so there have been smaller initiatives, there's been larger initiatives, but it seems pretty clear that if our court is going to continue to strike down the smaller initiatives that are meant to help, that there's going to have to be a fundamental change in the language of the Constitution.
Well, some of the bills I've seen, too, also limit the amount that you can sue for. And I suspect that'll be somewhere in what you all would propose, putting limits on what you can sue for. Is that correct?
That has been an option proposed in the past.
I would say if we pass this, it would be more of an option. And the last question, Mr. Chairman, if we do this, how much will health care costs drop? How much will we save the average person on health care costs? And I know the answer. And what's been your results in the other 40 states? Thank you, Mr. Chairman.
I think that there was, what comes to mind is a CBO study that was done. It's been several years. I don't know that the CBO has done a study recently, but when the CBO last looked at this, and they looked at largely the data that they had available, which is a lot of Medicare claims, what they found was, yes, healthcare costs would be lowered quite significantly if there was liability reform. I don't have that number readily available off the top of my head. I just know the study pointed that out. I'm happy to provide it to the committee so that you could take a look at it. My only caveat is it's several years old. I can't imagine that the results of that have changed, certainly given the rise in healthcare costs, but we can provide that. But based on the study, as I recall it, even though I can't remember the particular amount, it did lower healthcare costs because of liability reforms.
Thank you very much. Next question, Representative Prunty.
Thank you, Mr. Chairman. If I might add to what Mr. Meadows said, sometimes you can go to trial, and if it looks like the jury's going to award in the other favor, they'll make a deal too. So I've been there. My question is, in kind of light of the previous conversation and the shortage of physicians and needing a physician-led team, what's the data on, or do you have data on how many physicians have left Kentucky because of tort reform issues, liability issues? Because I know I've known OBs that have left or left the field completely or gone to other states, and I know family practice physicians have stopped doing OB for those reasons, and many other examples. But do you have any data on how many have actually left Kentucky because of it?
Not that I'm aware of. Like your experience, anecdotally, we hear it a lot. And I know anecdotes are probably only worth so much, but they mean it when it's coming from the horse's mouth when you're talking with physicians. So we know it exists. We know it's a real thing. No studies immediately or data comes to mind immediately, but we can give that some look and see what we can find that's out there. I'm sure there's been some probably national studies that have been done. That goes back really to a point that I think Senator Alvarado made, is data collection in this particular area is extremely difficult. We all love the data as long as we can quantify it. But oftentimes getting those thoughts and impressions about why someone stays here or leaves here can be difficult, especially if they're already gone. But we do know through studies that is a factor when a physician determines where to practice. So naturally, it backs up the anecdotal evidence that we hear, which can lead to why somebody would also leave. And so we know that's a real thing, and appreciate the question, but we can look into that further.
Thank you. I just comment that I feel like it's a very important issue for businesses, for hospitals, for medical. And I think it definitely refers back to the previous conversation. I think we need public assistance reform to get people engaged in the process and educated and taking better care of their health. I think we need the tort reform and other changes. So thank you for your presentation. Thank you, Mr. Chairman.
Thank you. Representative Elliott.
Thank you, Mr. Chairman, and I appreciate the discussion. I'm probably one of the few people here in the General Assembly who has voted both for and against tort reform in various forms. I look at it as independently as I can, being a lawyer, which is sometimes tough. One group that I think when we have these discussions that is often overlooked is that injured patient who has been, in a lot of cases, negligently treated. And so I don't want to leave those people out because they have to have the courts as a redress for their injuries. I don't support amending the Constitution. The Kentucky Constitution has 26 sections to its Bill of Rights. And I want to read Section 7. The ancient mode of trial by jury shall be held sacred, and the right thereof remain inviolate, subject to such modifications as may be authorized by this Constitution. And as you know, if we do pass a constitutional amendment, the people of Kentucky would have the ultimate decision on that. And I'll be honest with you, I think the people of Kentucky, in the form of a jury, have much better judgment than 138 politicians here in Frankfort. So that's going to be my argument on that if it does in fact pass. Abraham Lincoln had a great quote on the jury system. I think it applies here as well. So I won't go into that detail. But if it's good tort reform legislation, I'll support it. If it's not, I won't. But I don't support amending the Constitution. But ultimately, if we do pass it, the people of Kentucky would make that decision. And I think they would decide to leave that power in their hands instead of the General Assembly. So thank you.
Thank you. Representative Weber.
Thank you all for your presentation. So basically, we've heard today that there are two drivers for higher health care costs: liability issues, and then previously we had heard over-prescribing and referrals for testing by nurse practitioners and physicians' assistants. So which is the driver for higher health care costs?
Combination of all of them. I'm not speaking on behalf of PCJ or the Chamber or the Kentucky Hospital Association, but given that we've spoken on both topics, we would say it's multifactorial.
Okay, thank you.
Dr. Berg.
Sorry, it took me a minute to unmute. This is an honest-to-God question. I do not know the answer, and I would really like somebody to try to explain it to me. I have practiced medicine. I'm licensed, and I have practiced medicine in multiple states. And for many years, I worked at a small community hospital in southern Indiana. And in Indiana, you don't buy your own malpractice insurance. There's a statewide program. Every physician contributes to it. And the cost is significantly less than what I had to pay to be covered in Kentucky, for the same liability limits. Why can Indiana do that and Kentucky can't? I guess is my question.
The short answer is they have liability reform, and we don't have meaningful liability reform. And specifically, I don't want to speak too detailed, but it's my understanding they have things like medical review panels. They also have a concept called an injury compensation fund that providers and maybe other entities actually pay into, and it's my understanding they willingly pay into, so they can address not having to deal with it individually. They pay into a common system, and so when there's an injured patient, it's largely redressed through that that patient compensation. I think I said it's patient compensation fund. So that's the short and a little bit more of a longer answer.
If I can, yes, I do believe that every provider pays into this patient compensation fund. I do not believe that they have medical review panels. I as chief of staff, I went through a lot of legal, medical legal litigation potentialities in Indiana. I never dealt with the medical review panel. But we did have a patient compensation fund, and what each and every individual physician contributed both to the state fund for your malpractice coverage and to the patient compensation fund in aggregate was so much less than what I was paying in Kentucky. It was really interesting that the systems were so different to me.
Thank you, Dr. Berg. Indiana does, in fact, have a medical review panel system. It's been up and running. We used it as an example when we got our bill here passed. Thank you all for your presentation. We appreciate bringing light to this topic. We have one more presenter. And as always, I think it's like my eyes are bigger than my stomach. I think we can cover these things in a short period of time. But we have another important topic, All Payers Claims Database. And we have today Ben Chandler, who's the president and the CEO of Foundation for a Healthy Kentucky. And I believe we have a couple of presenters also from the Kentucky Primary Care Association, Chase Coffey and Teresa Cooper. This is a topic that many other states have implemented. We were hoping they could come and educate us today on what an all-payers claims database is, the importance of it, and why it would be a good idea here in Kentucky. I know there's been, I think, one bill already proposed. I've got one that I'm working on as well. And whenever you're ready, if you could introduce yourselves for the record and begin your testimony.
You want us all to introduce ourselves, Mr. Chairman?
That'd be great.
One after the other.
That'd be wonderful.
I'm Ben Chandler, and I represent the Foundation for a Healthy Kentucky. Mr. Chairman and Madam Chairman, thank you all for inviting us today. And I also would be remiss if I didn't thank everybody here on this panel, particularly the two chairs, for being so supportive of so many things that the Foundation for a Healthy Kentucky has been in favor of over the years. We are a foundation that is interested in improving the health of our people. And Senator Meredith, I was very interested in hearing what he said earlier, and that is that, among other things, we're not getting a whole lot of that done. We are not really improving the health of our people a whole lot. And I could say that. It goes back many, many years, many legislative sessions. Everybody, to some extent, has blame for that. It's an endemic problem in the Commonwealth, and we as a foundation are looking for as many solutions as we can to these problems, and they really are very, very difficult. One of the things that I think actually can move us down that road is an all-payer claims database. Now, I'm happy to tell you today, this subject, we're coming after the subjects of tort reform and scope of practice, so hopefully this will be a whole lot less controversial than the things that you all have been talking about. I'm hopeful that that's the case, because what we're talking about here, and we've had some discussion earlier about the lack of data and other places where you get data. Well, that's what this is about. It's a boring subject, but data is crucial. If you guys, if our elected members of the General Assembly are going to make decisions, and obviously you have to make decisions, you are sent here by the people that you represent to make decisions on their behalf. Hopefully those decisions will lead to measures that lead to better health for the people that you represent. And I'm sure everybody here in this room is in favor of that outcome. You can't make those decisions unless you've got good data. You just can't do it. You can't base it on anecdote. It just ultimately is a poor way to make decisions. You've got to have the facts. Now I will admit that we, to some extent, are living in a society now that doesn't necessarily follow the facts these days. I mean, we wonder, and we see all sorts of claims on the internet and on cable news on both sides talking about things that may or may not be true. But this is an effort here in the Commonwealth of Kentucky to actually get data that can be relied upon for decision makers. This is about transparency. It's about cost containment. It's about seeing trends in the medical data that payors pay for, medical procedures that they pay for. Those trends can give us some idea about where the problems lie. And frankly, what the solutions may be to those problems. And that's why we think it's so important. 19 other states have already set up all payer claims databases. 19 other states are ahead of us. We will not be recreating anything. We'll not be creating anything new. We'll be creating something that we've got lots of evidence showing that it's useful in other states. Really, it's about insurers and other payers, private insurers and government payers. Huge percentage, almost all of medical payments are made either by the government or by private insurers of one sort or another. All of those people would be required, hopefully, if you all were to pass this legislation, they would be required to submit their data of payments, and all of it would be protected. The individuals, it would be HIPAA compliant. The individuals whose data is being sent in would obviously not be discoverable by anybody, but you get trends and you provide that data to the public in forms that they have the opportunity to ask for it. Now, there are lots of different ways to do this. Again, we have lots of examples from other states, and I know that there's an effort in place now to try to see if we can come to, looking at these 19 other states, we can come to a scheme that would be suitable for us here in Kentucky and would provide the best of all of those other measures. We are very much in favor of this at the Foundation. We believe that it gives us one of the best tools. It would give us one of the best tools, again, to make the right decisions that need to be made to get ourselves moving in the direction of actually improving the health of our people. And we spend enormous amounts of time, and I understand why we do it, but we spend enormous amounts of time talking about health care. Health care is important. It's absolutely critical, and I admire all the people who are involved in it. But it's only a piece of the problem. As I say to so many people, I can't tell you how much I'd rather have health than health care. And that's really what we're talking about at the Foundation. We want to see our people be healthier. We want to see them be healthier on the front end. When they present to their physician, we'd like them to be presenting long before they have chronic or acute problems. And if they can do that, if we can get to that point in our society, we will save a whole lot of money, first of all, minor detail, and we'll have a much happier, I think, society. People, there isn't anything more important than your health. Nothing. Doesn't matter how much money you've got. If you don't have your health, doesn't matter. So what we're talking about here is more important than anything. And wouldn't it be better if we could see these trends, put policies in place that ultimately moved us toward better health? And I will stop there. I know you all already had a long session, and turn it over to you.
Thank you. Thank you, Chairman, Chairwoman, Committee, for inviting the Kentucky Primary Care Association to address this matter. The Kentucky Primary Care Association can offer an interesting perspective on all payer claims databases due to our existing partnership with KHI, as well as primary care providers' exhaustive relationship with patients from beginning of care to end of care and much of the coordination in between.
Before you continue, I need to have you introduce yourself for the record officially. Would be great so we can have you.
Thank you. I'm Chase Coffey. I'm the Senior Policy Advisor for the Primary Care Association.
And I'm Teresa Cooper. I'm the Director of Government Affairs for the Kentucky Primary Care Association.
Thank you.
And by the way, this is Allison Adams.
Yes, Alice,
I didn't introduce her, but you all, I think, know her very well, and she's here with me.
Very good. Thank you. Sorry to interrupt. Please continue.
Of course. Thank you, Chairman. Through our research, the all payer claims databases, we have decided to break the benefits down into 4 core pillars: transparency, accountability, utility, and quality. Transparency is at the heart of all payer claims databases. The collected data allows for provider comparisons, pricing comparisons, and exposes emerging trends in public health The data can be used to inform consumer choice by making it accessible and easily navigable. I know that for many of you, accountability is something that you have strived for since arriving in Frankfurt. All payer claims databases create equitable metrics by having data submitted through a common data layout, which harmonizes collection efforts and reduces the administrative burden of the data. The equitable metrics allow the stewards of the program to compare performance, cost, and quality, leading to better information on which to base future accountability measures on. Utility. Utility is also an important part of how all payer claims databases can be beneficial to the Commonwealth as a whole. These data systems allow users to access and analyze data to inform decisions regarding cost, utilization, and quality. The types of users vary based on the parameters outlined by each state, but typically public health administrators, employers, providers, and payers all have huge benefits to gain by having access to this data. Research of unidentifiable data by organizations such as universities can assist in driving innovation and quality improvement. Speaking of quality, the spectrum of data offered by implementing all payer claims databases can assist in identifying and closing gaps when only viewing data from one payer. In the end, patients receive better treatment with a complete history of treatment. Ultimately, all payer claims databases are mission-driven data systems which embody putting health before healthcare. They're a tool for policymakers, payers, providers, healthcare organizations, academia, and the general public, which provides ready access to comprehensive longitudinal data on healthcare services and their cost. This comparable data can be used to inform decisions on all levels in regard to population health, individual health, and the quality of healthcare in Kentucky. I would like to add one final point, if I may. I've heard this committee many times over the past few years discuss how the value of a dollar changes based on the impact that it has. A well-implemented all-payer claims database has the ability to vastly increase the value of that dollar, especially when it comes to employers and their health benefit costs. All payer claims databases can be used to establish broad-based measures and benchmarks to identify high-value services, providers, and health benefit costs. The all payer claims databases can be used to establish. This information can be helpful. I'm sorry, I'm losing my train of thought here. This information can be helpful in designing a health benefit product that maximizes the dollar by reallocating resources towards high-value care, which provides greater quality of services, care, and improves employee health, allowing the employer, both public and private, to get greater value per dollar on benefit cost while improving employee health and ultimately population health. It also addresses social determinants of health. Thank you for the opportunity to present on this subject. Are there any questions?
Thank you. Ms. Cooper, anything you want to add to that, or you're...
No, I think Chase
covered it all? Okay, very good. We appreciate that. I'll tell you a couple of things. Whenever we've had this topic before, I know several states have this. I know I'm kind of working off of a West Virginia model. They recently passed something, and some of these databases can be very, very detailed and provide a lot of info. The question always comes down to who controls the information and who controls the data, who can access that data. That's always a concern, and then what is done with that data ultimately. And obviously the driving interest for me as well is to drive healthcare policy, better outcomes, and how we can do that. I've had some folks who have been concerned about, in some states, what's happened is you'll have insurance companies request the data just to look at who's getting paid what. And so that it uncovers it for them to say, oh, this person, regardless of quality, regardless of whatever, they're getting paid a certain level, they're getting paid a certain, we're going to cut them from our services altogether, we're going to cut their contracts and reissue contracts at a lower amount to kind of undercut people after they've had a lot of that private stuff. So I want to make it clear that when we try to put this together and draft it, we want to create something that's going to help us collect data, drive better quality measures, be able to, we've had discussions in here about our managed care organizations who don't seem to know how to drive better quality outcomes. We've had 10 years. We haven't seen good quality outcomes. This can help us as a legislative body to be able to say, okay, these are the things we want to work on or what we need to work on, and to start pushing the direction for where the MCOs need to go, where the cabinet needs to go perhaps, and have that. But the one thing I want to be careful of is that we're not creating an opportunity from a business angle for people to say, hey, I'm going to get a business advantage to collect that data and undercut providers, because that would be harmful to the situation. You wouldn't get a lot of support. We've got the Primary Care Association, so clearly we know, and I think a lot of providers are interested in this. It just depends on how it's used. We want to make sure that we don't hurt providers, and I'm going to be very careful to work on that to make sure that if we can shield some of that information perhaps, and just to start driving towards diagnoses, outcomes, that sort of thing, and that we can get that better. So I just want to make that commitment. Go ahead if you want to make any comment on that.
Yeah, if I could address that. We believe that those concerns could be addressed in the contract agreements once the legislation is implemented.
Thank you. Yeah, and that's going to be important, I mean, for my support as well, and I think for a lot of folks. We've got a few questions. Representative Bentley.
Thank you, Chairman Alvarado. I'm concerned on this transparency. Is this pricing comparisons? You know, I can remember the day when I went to a meeting and ERISA laws were in place, and I had to sign a contract. I wouldn't even compare prices with other pharmacists. So how does that get around that? And that question is for the congressman.
Well, I mean, I think that what we're talking about, the transparency, is just absolutely critical if consumers, for instance, are going to have any idea what they're paying for. You know, you've got to be able to address that somehow. If it is a central problem, I think, with the healthcare system in general, is the lack of transparency. So that's something that I think most everybody ultimately is in favor of. Certainly the general public is in favor of it. I would also say in response to what Senator Alvarado and his concerns, you all have the ability when you're fashioning this legislation to make sure that you put things in place that protect providers. And I think providers can be protected in this regard. You can decide who has access to this information and what information they have access to. And that's what needs to be discussed, I think, throughout this process. And I would advise you to look at, again, the best practices of these 19 states. I think you can mine a lot of very useful information from the experiences that these other states have had on this particular subject. And you can find out where you've run into a problem like that. If another state has run into a problem like that, fix it before the legislation goes into place. I don't really think it'll be that much of an impediment.
What do we call you, Honorable Congressman, or?
Representative Bentley, I have answered to many, many things over the years. Some a whole lot nicer than others, but just to be able to be called is a very happy thought for me.
I just want to be appropriate because
I'll answer to anything from you, sir.
Representative, I call him Ben if it's any consolation, so I consider him a friend.
I used to visit him in D.C., so I want to be proper.
I was just thinking about it on the way over here. I was Attorney General here. It seems like yesterday, but it was 18 years ago, which is hard for me to believe. That's when I actually left office. And Susan Westrom, who's getting up right now, I think is the only person on this panel who's actually in the legislature when I was Attorney General. Now, I don't mean to age you, Susan, but I'm certainly aging myself.
Well, and to the topic we were talking about earlier, I mean, that is, Representative Bentley, a concern I've got. And so, again, this might be like the telemedicine bill. The first time we passed the original bill, it was more of a skeleton base. Let's get this thing started. And then we were able to add to it as we went along. Representative Fleming, you have a question.
Thank you, Mr. Chairman. I appreciate the question, the opportunity to ask, and appreciate the folks coming in and talking to us about data. And of course, I like data and so forth. I want to say thank you very much for the question in regards to control, but I want to ask the Congressman, Secretary of State, Attorney General, and whatever else you want to call him as he describes himself.
He added one office to me, and I appreciate that, Ken. Thank you.
You're everything. You're a politician everywhere. So, no, we go back a long time. But I do want to ask two serious questions. One, when you talked about best practices, what are the data sources that are used to apply or go into the best practice? And second, how is the data scrubbed to ensure the data integrity?
Well, again, I mean, that's that when you're putting the legislation together, I think you're going to have to look at how best to do that. And I don't have an immediate answer because there are a lot of different ways that states handle this. We've got 19 states that do it, but there are certainly there are examples before you which work very, very well that will handle any of the scrubbing of information. And I don't think it will be difficult at all for the staff. And I understand that some folks are going to be sitting down together to be looking at some of these practices to come up with the best overall plan. But I think that we'll come up with a very good one, and I think that they will take into consideration the protections that are necessary for people.
Okay, well, I appreciate that, and I'm sure there's quite a few folks will be putting in some criteria and language into the bill, and I'm sure the chairman is going to do a good job in terms of coming up with that. He's always very thorough with all that stuff, but I appreciate it, and thank you, Mr. Chairman.
Thank you, Representative. And again, Representative Bentley and Representative Fleming, I welcome input. I've got a very early draft. I'll be happy to share with anybody who wants to review it and have some input on it. Because we're still, again, early phases of putting this together. Again, even at the very least, I'd like to get a skeleton base for this that we could build off of if we need to in the future. But we want to make sure that we do something that's going to allow us to collect data. We don't want to hurt providers. We want to make sure that it's something that's worthwhile and it's a tool that we can use moving the state forward. Senator Meredith.
Thank you, Mr. Chair. And I guess this question's for His Supreme Royal Highness.
That one, Senator, is a new one. I think I'm not sure whether that's positive or negative either.
Most certainly it's positive. I can certainly embrace this in theory, but practical application is another issue altogether. Who's going to interpret this data?
Well, you're exactly right. Theory and practice are two different things, and that's why I would encourage the group here to look at what's happened.
Well, the reason I asked that question, and we have data now. We know that hypertension is a big problem in Kentucky. We know that we had a presentation just a few weeks ago about hepatitis C. It's a big problem in Kentucky, but we're not doing anything with the data. So what mechanism can we put in place to ensure that we're going to actually use this data?
Now, that is frankly up to the members of the General Assembly. I mean, you guys have got to decide what you're going to pass and what you're not going to pass as far as using the data. I would, if I were king, I would. There are quite a number of things that I would do that you all probably wouldn't let me do.
To that end, it's not meant as a rhetorical question, but who's responsible for the health of Kentucky?
All of us. But you guys have a particular responsibility, obviously, because you have a responsibility of trust to your constituents.
Well, my contention is we have delegated that responsibility, and what becomes, if everyone's responsible, no one's responsible. I think it's part of the issue.
Well, but it is certainly part of the issue. Everybody has a personal responsibility for health.
They do, but somebody's got to drive, and maybe it goes back to being king, and that's one of the things that I push for is somebody needs to be responsible. Why shouldn't it be the Department of Public Health in Kentucky? Somebody needs to be held accountable. There is none. We delegated this to the MCOs a decade ago. They've not improved the health of the population. So
you're right about that, but at the end of the day, I think the buck stops with the people that we elect, quite frankly. Having been in that chair myself before, I think the people that we elect, both in the General Assembly and as governor and other offices, the federal offices, those people have to make decisions on behalf of the people that they represent. And it's a heck of a messy process. We all know that. Having been in the middle of it, it is a very messy process. And when you've got 138 people, each of whom are elected by a similar number of citizens, they can disagree about a thing or two. As you've heard people say, good luck if you can agree with your own spouse on most things. But to get full agreement with 138 people is not easy. And I think that's why we have the problem that we have.
Well, there's
we wrestle around and try to make the sausage, and it isn't easy to do.
Well, there's a couple contributing factors, one being that I think everyone wants the best health care that somebody else's money can buy. And secondly, nobody thinks about health care until you need health care, and then you demand it.
You know what we've done? We have essentially created an economic system in this country. And this, people don't want to hear this, but we have a lot of jobs in this country that are tied to making people sick and producing such things as tobacco and certain foods that have very little nutrition and high level of calories and so forth and on and on. And then we've created on the back end a rescue system to rescue those people who we've made sick to begin with. Now, it's a societal problem. Nobody is responsible for it, and that is part of the problem. Nobody is responsible for it, but it's been institutionalized in our society. Part of it, frankly, is due to freedom, I think. We have the freedom to eat what we want and not exercise if we want. The result of that is that a whole lot of the rest of us have to pay to rescue those of us who don't behave in the right way. And you all know that's true.
Well, maybe that's part of the solution is, I think we have addressed the issue of smoking. We have raised taxes to make it less affordable for people. I think that has impacted it. I'm that way. You can smoke all you want to. I don't care. Don't make me pay for your health care.
But we do pay for their health care anyway. See, that's the problem. When they present, we pay for their health care because that's a central belief in our society that we ought to pay for people whether they behave well or not. And it's just it's a tough nut. It really is. And
I'd like to see the data. Just at this point, I'm not confident that we'll use the data.
Well, we can't use it if we don't have it. So let's at least have it and give us a shot of using it.
Sure. Thank you, Mr.
Thank you, gentlemen. It's always I had this discussion with my brother last night. It was his birthday, and it was the discussion of other countries do not require treatment from hospitals. They just say, you come in and you're sick and you're dying. Do you have money? If not, I got a paying customer. When I'm done with them and if I feel like it, I'll provide you care. America hasn't done that. As America, we take responsibility. We have a moral obligation, we think, to our fellow citizens. We've done that. That's part of what limits us and makes it difficult. So that people can make decisions about their own health care. They may have a negative outcome towards those decisions. As a society, we've agreed to help with that. And it's a moral dilemma for Americans, but it's one that I'm proud that we take on. Other countries don't seem to have as much of that issue. So thank you all for coming and presenting today. We'll be working on this. And like I said, anybody who has any information, I welcome their input on that. I'll be happy to share it with anybody who wants to see the language of it. That concludes our business for today. Our next meeting is scheduled for Wednesday, December the 15th at 1 p.m. I think the chairwoman and I have discussed some potential bills we might be hearing in the session coming up. So we'll be having an opportunity to talk about some of those, even if it is briefly, just to have the committee aware as we start entering January into regular session. Unless there's any other business before the committee, we stand adjourned. Thank you.